we're going to kind of tag team this because this is the Mayo way. The Mayo way, aside from the teamwork, is that in major initiatives we have a physician administrator partnership in leadership. So we do want to represent the physician perspective. Dr. Ferris Tamimi, as my colleague is our medical director, came on fully on board last fall. He gets about 10% of his time actually paid for, dedicated for this role, and he probably gives us 3-4 times that. So we're delighted to have him with us to be able to participate in the physician panel and also to help us tell the story, as we call it here, the social media imperative. Some of you may be here today because of a blog post from Chris Boyer and from Ed Bennett. It looked something like this. This is the version that was on Ed's, and down in the 10 reasons why this is a great conference to attend. One of those reasons being you get to see Lee Acey in shorts. And so I think it was something about the warmth of the weather and stuff like that, and since not wanting to disappoint you all, this is, actually it doesn't show up all that well. Darn. Yeah, so. There, yeah, it's probably better up there. So this was in Times Square on Tuesday night.
Athletic legs, very athletic.
Yeah, so, and with my daughter Ruth, and we are here today. So if Ruth and Rebecca would stand up, please. What's that?
Come on.
Okay, who wants to tweet this? Sorry, he wants to tweet this one first, so here we go. He wants to take a picture and tweet it, so has to get around the world. Very good. So this is Ruth and Rebecca. So they're here. This is Take Your Daughters to Work Day. So at any rate, our agenda for today is we want to take you through a bit of Mayo Clinic social media history, talk about 2 social media indicatives, and then 8 healthcare social media imperatives that result from those indicatives, and we'll get into the whole indicative imperative distinction in a little bit. But first I wanted to direct you to or highlight a blog post that I did on our Mayo Clinic Center for Social Media site just as we were preparing this morning. So some of you may have seen this actually happening while it was going, but this is the post about today's event. And as you'll see, I've got the slides embedded here. So we're going to go through, as you see, 135 slides. So don't bother taking notes. They're all here. Actually, they're almost all here. The ones with my photo in Times Square are not there.
But I can make them available if you email me at your
for a price. Actually, they can be made available here. So here we go. This is the history of Mayo Clinic social media. It actually started with Dr. Will and Dr. Charlie Mayo, who were Mayo Clinic's first social networkers. Mayo Clinic now is in our original campus. Our original campus is in Rochester, Minnesota, a town of about 85,000 people, and yet everybody's heard of it because of what Dr. Will and Dr. Charlie did in social networking. They were both surgeons. One would stay home, and the other one would go out and teach and learn all over the country, actually all over the world. I was in Sweden about 1.5 years ago, and it was the 80th anniversary of Dr. Will having been in Sweden. And he had to go by boat, so they really had this commitment to outreach. But then they would bring people also then back to Rochester. So one would, Dr. Will, I think, was in Chicago, and he was talking about the 30 gallbladder operations they've done. And they said, "Shut up." Well, that's not what they said back then. That's not how they talked back then, but they said, "Really?" And they got on the people from Chicago got on the train and came and saw the records and said, "Wow, yeah, really, they actually have done this in the middle of a cornfield," but because of the great surgical outcomes they were getting. But secondly, they invented internal social networking in healthcare because they also invented the group practice of medicine. Before their day, kind of in frontier medicine, there was really no communication among physicians because each physician was responsible for his or her own patients. But as they invented the group practice of medicine, then with Dr. Henry Plummer, who was their first partner, he invented the medical record, the internal medical record, which was a social networking tool for the medical practice to help physicians come together around the patient to communicate and share information. As we look at what social networking what word of mouth has meant for Mayo Clinic over the last 100 years, This is our brand research when we look at reasons for preference for Mayo Clinic. Word of mouth is the number one thing. Stories in the news media, number two. The power of social media is how it combines those and gives you word of mouth with legs. Not like legs like on my shorts and stuff, but legs that go all over the world. Our starting with social media at Mayo Clinic began as an outgrowth of our media relations, because that's what I was hired to do in April of 2000, was to work in our Department of Public Affairs. We began a program called Mayo Clinic Medical Edge Television in April of 2000. It was a weekly 90-second TV package that we provided to stations in the US and Canada. We followed up in 2004 with a daily 60-second radio segment. And as I heard about podcasting in 2005, I heard, well, that's just a way of subscribing to get audio files sent to you. So I said, well, we have audio files on our website already, and this is when I used what I call the proceed until apprehended model of innovation. We created an RSS feed, listed our podcast in the iTunes podcast directory, which was about a month old at the time. We saw our downloads go from 900 a month before the podcast to 74,000 in the month after the podcast, which just gave us some internal traction because previously our focus would be and should have been on the big media, New York Times, Washington Post, Chicago Tribune, Star Tribune, then likewise the similar TV outlets and radio. But seeing that kind of appetite gave us the ability to take a step back and say, okay, what would be the right way of doing podcasting? And how would we want to deal with this whole new media world? And we made the analogy between genomics as being personalized medicine, that social media, or what we called new media at the time, would be personalized media. That instead of having to appeal to the lowest common denominator, we could provide in-depth information that would help patients directly. I just wanted to emphasize that first we said we didn't want to do blogs, not that we didn't want to, but we specifically said let's change our processes, look at how we can produce content that's more in-depth without doing blogs, because we didn't want to take doctors away from treating patients. We didn't want to be hassling people like Dr. Tamimi to write blog posts for us when they should be taking care of patients. We also didn't want to be ghost blogging for them. We didn't want to write something or hire freelancers, and so it just didn't make sense to us at the time. I did, however, start my own blog at the time. I called it Lines from Lee. It was mainly just a way to get hands-on personal experience. But as we took a step back and said, how do we produce the right kind of podcast? We said the daily 60-second radio segment was kind of like the hypochondriac feed. It was sort of here's a disease you can have today kind of thing. And we said, how about if we create more in-depth podcasts and actually categorize them and have things like men's health, women's health, children's health, bones and muscle, cancer. It isn't really important that you be able to hear this audio, but mainly what you should see is it's about 8 seconds of his lips moving. And this is Dr. Phil Fisher talking about a condition called postural orthostatic tachycardia syndrome, and it's emblematic of the process change that we made. Because when we're interviewing these doctors for the 90-second TV package, we're interviewing them for 25 minutes maybe, and for that 90-second package that has an 8-second soundbite. But there's a lot of other great content, or about 99% of it, that was on the proverbial cutting room floor. It was being used to inform the piece, but it wasn't actually making it to the consumers. And so we said, if we put a microphone on the interviewer as well as on the doctor, and then strip out the audio track, and do a little post-production editing, no more doctor time involved, we could provide a whole new rich resource, which in this case, Dr. Phil Fisher, this is actually our most popular podcast on POTS syndrome. It's a condition that affects primarily young girls. They go from laying down to standing up, and something is triggered in their nervous system that causes their heart to race, the blood pools in their extremities, they feel icky and sick, and then they go to the doctor who says, you're a teenager, you're under a lot of stress, it's kind of all in your head. And but there really is a medical basis behind it. And because it's so underappreciated, this podcast itself had more than 60,000 hits and 62 comments before Dr. Fisher finally said, I've answered every general question there is. let's just put a number where people can call for appointments. But this was a way of getting additional resources out. This is that podcast, again, on postural orthostatic tachycardia syndrome, 22 minutes. We found out shortly thereafter that we were represented in social networking, whether we liked it or not. This is, if you go to myspace.com/Mayo Clinic, you will see a page that looks very much like this. It's updated a little bit in the look, but that's one thing they haven't updated. This is actually, it's nothing to do with us. It's a British rock band that goes by the name Mayo Clinic. So we're pretty excited about the brand imagery, and it actually gets even just a little bit worse. But the positive side of that is that when Facebook made pages available to organizations, we got same-day approval to head off the British rock band from making its invasion on Facebook. A pivotal presentation for me was one that I made to the Association Forum of Chicagoland, asked to do a 20-minute Facebook 101 course. I got some in-depth questions, and people, and I just sort of joked, that's in the 201 class when I was responding, which told me there's an opportunity to rebrand my blog. I rebranded it from Lines from Lee to Social Media University Global, and named myself the Chancellor. So I won't go into a whole lot of what Smug's about, just say check it out. But it's kind of fun to be, a chancellor of my own university. We got into YouTube in 2008. Actually, Andy Cernovitz, Julie, where are you? Yeah, so Julie's there, yeah. Julie's husband, Andy Cernovitz, was a consultant that came in and helped us make the case. The quote from him was, "The world has voted and we want to watch videos on YouTube." And it just helped us make the case internally that this wasn't a non-serious place to be. It was a place to share videos with patients. We started out with using our Medical Edge TV segments, the video segments we were already putting on TV, and saying, let's just put them on YouTube as well. We also then joined a group that Andy had formed called, back then it was called the Blog Council, then Social Media Business Council. I think now it's socialmedia.org is the official brand they use for it. But big companies using social media, and Mayo's one of a couple healthcare providers involved in it. But people with the common denominator is large bureaucratic, multi-billion-dollar organizations using social media, and how are we affected? A transformational point in our use of YouTube came shortly thereafter, actually going to one of those blog council meetings, and I sat with Adam Brown, who's my colleague at Coca-Cola, and we had been trying to get using the flip camera, and we were meeting some internal resistance, especially among the video purists who said, thought it as a sign of the coming apocalypse that we would use a camera like this. But when Adam Brown was saying that they were using the flip to video blog the Beijing Olympics, that gave me ammunition to take back and say, Coca-Cola is kind of a big company, and if they're using it, we can too. We've got 1,900, almost 2,000 videos on our YouTube channel, and if we had to send a $25,000 camera with an extra person to go do every one of those interviews, it just wouldn't happen. We launched our podcast blog in April of 2008 because we now realized we had enough content. We had enough fresh content because we're producing at least one a week with stripping out the audio from TV. We got on Twitter just over 4 years ago, again to keep the Brits at bay. And then started using blogs internally for discussions around our strategic plan. This is what we call our Let's Talk site. Then our flagship blog was launched in January of 2009 called Sharing Mayo Clinic, a chance to share patient stories and to share stories about our employees. This is one that kind of blends both of those. Story of Dr. Mike Ackerman, who is a pediatric cardiology fellow, and he was taking care of a little girl named Stephanie from Michigan. Stephanie was going in for a heart transplant. She was 8 years old. She said, "Dr. Mike, am I going to live?" And he said, "Stephanie, of course you're going to live. In fact, I'm going to dance with you at your prom." And this is the story, and here's where the goosebumps going up my head of when he surprised her. He just showed up at her prom 10 years later. And thankfully, they could have had a flip camera. I would have liked that, but they at least had a still camera. But this led to Dr. Mike and Stephanie and her parents being flown out in the CBS Early Show to be live in the studio. But I'll also just say, as a Mayo employee, Dr. Tamimi is a cardiologist. I mean, it makes you just really proud to work at a place like that, and from building we're going to talk about the moral imperative. This is a bit of the morale imperative of using these tools. Our Connect site, connect.mayoclinic.org, is sort of our version of Facebook. We launched that almost a year ago now. It was in July of last year. It's got about 19,000 people part of it. A way for people to talk about health-related issues, not using their Facebook account, so their Facebook friends don't have to know. Now we want to take a bit of just a little segue here to give you a little refresher on verb moods. Okay, so nobody thought that they were going to get like an English grammar refresher as part of the deal. It's bonus, no additional charge for this. But indicatives, the indicative mood it's just talking about reality. It's talking about what's out there, and then imperatives are our responses, or as we say, exhortations. I mean, what we think you should do, and actually what we'll be talking to you about is what we've seen as the imperatives of based on those indicatives. And the first indicative is the millennial, and we'll give it to Ferris for that one.
So I'm just curious, how many of us are healthcare providers? Actually, a nice penetration. So if I have one overarching message that I want to provide, engagement for healthcare providers is predicated upon identifying the operational need. So those of you who are facile at social media tools, your obligation is to go to your providers, identify what their particular policy procedure need is that can be met with social media tools. And that's the message that I think that underlies the majority of what I want to say. And it's important to me that you take that home. It's not just a matter of getting doctors on Twitter. You've got to speak with them, identify what their needs are, and what tool you have to meet that need. You have to be facile with tools and be credible, certainly, but you've got to be able to identify what their needs are. Now, from an operational perspective, one of my needs is taking care of my patients. And the majority of my patients are like my son, Everett, who's 4 and uses an iPad better than I do. Half the world were born in 1983 or later. This is not only our future, this is our present. 26% of, sorry.
Millennials are 26% more likely.
26% more likely, I need bifocals,
Yeah.
than other adults say the social network is an important part of their everyday life. In 2010, a study suggested that quitting social media created the same withdrawal symptoms as quitting a stimulant drug. These are our future and our present. They own computers, they own cell phones, they own MP3 players, they instant message. The majority, when they instant message, multitask while doing so. And about half of them get their news from sources other than television news.
So that comes back to this is the symphony. We're going back and forth with this, but the second indicative is the mass media malaise indicative. Yeah, I just want to make sure everybody can hear. And I just have one slide to illustrate this, and it's kind of a sign of the times, almost literally. That if you were to Google paper cuts, this is a blog dedicated to tracking newspaper layoffs. And so far this year, already this year, 991 job losses that they've tracked in the news media, or excuse me, just in newspapers alone. And that just indicates how the audiences are fragmenting. People are getting their news in other ways and not necessarily going to the traditional mainstream media, which leads to the first of our imperatives, which is the media relations imperative, that instead of necessarily buying the space in the mass media, that if you're able to leverage your content, yeah, probably that'd be good to put that down. If you're able to leverage your content, you can have a powerful impact at ridiculously little cost. And so I want to just share a couple of examples here. One that some of you may have seen, but if you haven't seen it, you need to see it. This is the story of Fran and Marlo Cowan. Marlo was 89, his wife Fran was 83. They were captured by another patient playing the piano in our Gonda building atrium. That patient uploaded the video to YouTube. It was on her YouTube channel for 6 months, had been seen 1,000 times. When I saw it, I embedded it in our Sharing Mayo Clinic blog, posted it to Facebook, and tweeted it. The next day it was 3,800 views. By 6 days later, it's at 28,000 views, so about 25 times as many in less than a week as in the previous 6 months. By April 22nd, it's at 65,000 views. May 3rd, 188,000 views. A red letter day for us, that was when it was in Random Lunatic News, something I'd always personally aspired to. More importantly, it was on fart.com, given the cool tag because there's no awesome tag. So May 4th, it's at 228. May 5th, 292. By May 10th, it was at 555,000 views. Now that was, by then we had been in touch with Mr. and Mrs. Cowan, asked if we could pitch their story to the media. They lived near Ankeny, Iowa, near Des Moines, and May 10th was the day they were in the Des Moines Register. Featured on the front page of the community section, also online, they interviewed them in their home, and you see Mr. Cowan there saying, "What tube?" Because he was now 90 years old, still didn't own a computer, had only seen this on his friend's iPhone. But still, he was an internet rock star. By May 11th, they're at 608,000 views. May 12th, they crossed the 692. By May 15th, it was the 1 million mark. By May 26th, the 2 million mark, and that was the day that they were live in the studio in Good Morning America. So we're about on the third anniversary, almost on the third anniversary of that happening. And for those of you who haven't seen this, I want to take the next minute 15 to make you stupidly happy.
Over here.
So I stayed in touch with Mr. and Mrs. Cowan. We'll come back with the sound on this in a little bit, but a few months later I got an email from their daughter saying, would you like to schedule a concert? Because Dad's coming back for an appointment. We did schedule a concert, captured it on my flip video, put it on our YouTube channel, which led to a Japanese-American blogger from San Diego seeing it, which led to NHK Television in Japan seeing it, which led to this interview on NHK Television using something like Skype.
そこでドゥーガでは投稿者を通じてお二人に連絡を取りお話を聞きました。
We didn't even know we were on YouTube.
No, we didn't know what YouTube even was.
We didn't know what the word meant.
No,
So we
we're
had
still
no,
not sure.
今年2月、あの病院に多くの観衆や報道陣が集まりました。動画によって世界的に有名になった夫婦のコンサートが開かれたのです。
And so the results of this, more than 8 million views on YouTube, 1.5 million of those on our blog. And so this isn't about core competencies of Mayo Clinic. On the other hand, it's getting people to our blog and helping them get to see some other stuff. And that's actually, okay, so that's second element, and this is actually going back a little bit in time. We started using social media for media relations as a way of making resources available for journalists. Instead of spending $10,000 to set up an online newsroom and then $1,000 a month from a vendor to provide audio and video resources, we used a blog. We used WordPress.com for about $50 a year, and we're able to make the audio and video resources available on a pre-embargo basis. For those of you who work in media relations, you know what that's like. But then making them available after taking the password protection off afterwards for the general public to be able to see. First good example of using this came up when Dr. Victor Montori, who is Dr. Tamimi's predecessor as our medical director for the center, had a study published in JAMA. And normally, if you work in media relations, you know, you'd like to have some advance notice so you can write a news release and get ready to pitch it. Well, we found out about it 6 hours before it was coming off embargo. But because we had the blog and the flip camera, we're able to interview Dr. Montori within about an hour and a half of learning of the study, getting it uploaded by noon that day. So this is from 9 to noon, we got it loaded, and pitching it. And the next day, the Wall Street Journal Health blog embedded our video within their story. which just gave us some momentum on how this could be used, how these tools could be used in our traditional work. As Dr. Tamimi mentioned, you don't want to be pitching stuff to physicians about, oh, here's a new thing you should do, you should just get on Twitter. We were not wanting to tell people, hey, use a flip camera just for the sake of it, but to enable us to get the end result, which is what we were looking for. The same thing that we originally hired to do. The next step that we've taken is creating what we call the Mayo Clinic News Network, which is actually blog-based as well, but it's creating a rich multimedia resource. So it's newsnetwork.mayoclinic.org as a way for both traditional journalists as well as bloggers to be able to get access to health-related resources from Mayo Clinic. The marketing initiative. So we've had the media relations initiative, the marketing initiative. These aren't necessarily in order of importance, just more in order of how we've gotten to these. Dr. Ruben Mesa is a blood cancer specialist at Mayo. He did this 10.5-minute video on myelofibrosis. It's not going to get 7 million views or 8 million views like Mr. and Mrs. Cowan, but it got 10,000 views. When I took the screenshot, it's actually up to about 12,000 now. But what he has said, and this is an email I got from him just about a couple years ago, where he said, impact's been huge. I'd conservatively say at least 50 people coming to me mentioning this video, probably every out-of-state patient I see mentioning this. I saw him about a year ago right now, and he said we're in the hundreds. And in fact, we went back and did some research, or we looked back at at the growth of the practice. So this is our Arizona practice versus our Florida practice. And when he moved down to Arizona, actually the Arizona practice was a little bit smaller. It has since doubled. It isn't all because of the video. It's part of a coordinated approach, but social media plays a role. And I guess that's the part that we'd like to make, is social media isn't the cure for everything, but it can play a role. Another example of this leading to some pretty significant outcomes that bridge both social media and are both media relations and marketing. Dr. Richard Berger had this discovery of a kind of split tear, a tear of a ligament called a UT ligament split tear in the wrist, where instead of a complete rupturing, it's a splitting apart like a celery stick. And he discovered, so nobody had seen this before, I guess that's what discovered means, but nobody had seen it because it doesn't show up on an MRI. But if he discovered it under the arthroscope, also discovered how you can fix it by scooping out the inflammation, giving it a couple stitches, and 95% of patients are back to normal after 6 weeks in a cast and after rehab. Now the bad news is if you have this injury and you don't get that operation, you never get better. I mean, cortisone doesn't fix it, nothing works. So he discovered this in about 2001. Over the next 4 years, he was examining every patient that came to him who had unexplained wrist pain and finding out that it's surprisingly common. He thinks it's probably as common as an ACL tear, but had never been seen before. So then it was time to, how do you spread the word? How do you let other doctors know about it? So the traditional way is through journal publication. Just as he's getting ready to do that, there's a baseball player by the name of Jason Worth, who's playing for the Los Angeles Dodgers, got hit by a pitch in spring training. Over the next 17 months was on an odyssey trying to find out what was wrong. Actually ended up having an operation that made it worse because it didn't fix the problem. And by August of 2006, thought he was out of baseball, thought he was done. But he was met at the mailbox by a family friend, a physician who'd done an internship at Mayo Clinic, and he said, his friend said, you ought to go see Dick Berger at Mayo Clinic. He didn't know anything about the UT split, but he said Dr. Berger's one of the best. Well, Dr. Berger had also discovered how you diagnose this, that the MRI doesn't work so well, but if you push really hard right here, and if your knees buckle and you scream, it's like 95% sensitive and specific. Chuck Norris or Jack Bauer, somebody like that might just smirk a little bit, but for everybody else, it's not ambiguous. Jason had a positive result on the test, also had the operation the next day. 3 months later, signs a contract with the Philadelphia Phillies for $850,000 a year as a spare outfielder. 2 years later, fast forwarding, he's playing in the World Series, and I'm thinking, what a great story. I mean, I'm a media relations guy. It's the great story to tell. Well, I don't know if I started too late or just wasn't very persuasive, but we didn't get any media pickup. So fast forwarding a few more months, I was in Philadelphia with my flip camera and got to interview Jason in the dugout. He was delighted to do this, so we at least got the video there, got that embedded in our Sharing Mayo Clinic blog, and I felt at least we told the story in some way. A few months later, he hits a couple home runs to send them into their second World Series. This time we were not asleep at the switch. We got this in our news blog, posting the transcript in addition to the links. It was way more convincing when the player himself was telling the story versus the PR guy telling the story. The Post Bulletin in Rochester did this nice story. One of our TV stations actually used our video over the air. But the great thing was USA Today. They picked up on it. They did a half-page story on this relatively common injury that's unknown, using Jason's example as the hook. That would have been in the old days. That would have been declare victory. Wow, we got a great story in USA Today. But as we thought about it, we said this is an opportunity to help educate people. And so we asked USA Today, what if we scheduled a Twitter chat with Dr. Berger to coincide with the publication? So that same afternoon, we did a 1-hour Twitter chat with Dr. Berger. And a few months later, saw this blog post from a woman named Erin Turner in Washington, D.C., who started her post. When I arrived at Mayo Clinic in Rochester a few weeks ago, I was asked who referred you to us. My answer was not traditional, Twitter. So she had participated in that Twitter chat, had seen the video of Dr. Berger demonstrating the test, had given it to herself, and this is what she said in her post. She said, I now have a chance. Well, first of all, she's 28 years old. I'll let you read this for yourself. She's 28 years old, had this problem for 5 years, and was looking at 5 decades of it never going away if she doesn't have this operation. But now she says, I have a chance at a pain-free future that without Twitter and those in the medical community willing to experiment with these new tools might not exist for me. The other follow-up is that the Nationals, the Phillies opened their season with the Nationals where Aaron lived. We arranged for them to get to meet, for Aaron to say thanks. They got to compare scars, and USA Today just happened to be there. So it was a really neat deal. This is what Dr. Berger had to say in his in an email a few months after that. He said, social media has driven this into practices in less than 2 years when it takes 17 years on average. So it's really making a difference in helping others know about this. The other fun sidebar is that a year ago in December, Jason signed the 13th richest contract in the history of Major League Baseball. So $18 million a year. So going from out of baseball to $18 million a year. We're thinking a philanthropic response would be good here. And when he opened the season with the Washington Nationals, the second paragraph of that story was about his experience at Mayo Clinic. And this is what it's meant in our practice. So 2009 was when he was in the World Series. 2010, through a combination of the social media and the mass media, saw nearly a doubling of the number of patients seen for this. Now the bad news, some of you might have seen about 10 days ago, Jason was injured, and but I guess when you've had somebody give you an $18 million contract, kind of help you achieve that, he decided he was going to go back to see Dr. Berger for his surgery for that as well. Talk a bit about the mobile imperative, and we're going to have a whole section on mobile here, so we don't want to talk too much except just to say Mayo's response to this is this week we launched our first big comprehensive app, and would invite you to check that out. It's got, you don't have to be a patient, but if you are a patient, that gives you access to lots of different information about your medical record. This is my medical record with my clinic number blacked out, but these are my hemoglobin levels from the time that it was discovered that I had celiac disease and wasn't absorbing my iron. So it's a really, really handy app. I invite you to check it out, but we're definitely seeing mobile as a huge area that we need to be involved in. And if you go to bit.ly/getmayoapp, that'll take you right to the App Store. It's only in iOS right now. Android's coming in a few months, probably. The management imperative.
As I was doing that little tease. Oh, that little mark with the A and then the ring around it.
At.
See, that's what I said. Katie said she thought it was about.
Yeah. Oh.
But I'd never heard it. I'd never heard it said. I'd always seen the mark, but never heard it said. And then it sounded stupid when I said it. Violence at NBC.
I heard it around or about in the lunchroom.
See, there it is. Violence at NBC. GE.com. I mean.
Well, Allison should know.
What is internet anyway?
Internet is that massive computer network, the one that's becoming really big now.
What do you mean? How does what do you write to it like mail?
No, a lot of people use it and communicate. I guess they can communicate with NBC writers and producers. Allison, can you explain what internet is?
Okay. So Bryant Gumbel and Katie Couric aren't dumb, okay? And this was back in 1994. They were just unfamiliar with this stuff. And so, but now none of you could imagine doing your work without email, okay? So to the point where you can't believe how much email you have, and it's maybe even driving you crazy. That's where we see the management imperative is to provide tools to help our employees to be able to communicate effectively and to go the step beyond email. So one thing that we've just, and actually in this next week we're going to be officially launching at Mayo Clinic, is we're using Yammer as an internal social networking tool that's an awful lot like Facebook. It looks, the interface is very much the same. So we've got people that are familiar with using Facebook, they'll be able to use Yammer. And in fact, in our news center redesign, our front page, you'll see that down in the lower right corner, we're actually going to be incorporating feeds from Yammer, from Twitter, and from our Facebook page in our intranet as a way of helping our employees get more familiar, those who are not the half of the world born less than 29 years ago. Getting people familiar with these tools and introduced to them.
I'm sorry, how old do you think I am?
Oh, no. And then also part of the management imperative is just to provide guidelines, that it's important that we provide resources. So if you go to our Sharing Mayo Clinic blog, there's a link that says for Mayo Clinic employees where we published our guidelines for employees. We're also providing training, things like this conference, like the one that we're doing in Rochester, our social media residency program. We want to provide them the tools to learn how to do this stuff. We'll let you take the medical practice imperative.
So I'd also be remiss not pointing out that Lee's birthday is this week as well, 2 days ago. So for those of you who have not purchased a gift for him, there's still ample time. There are shopping opportunities available here in the New York area. So again, I was saying earlier, it's important to identify operational needs that can meet a provider's requirement. Now, this is Sri Koka. He's the chair of our dentistry practice. And one of the repetitive parts of his day when he sees patients in clinic is explaining who he is, what he does, what he can offer you, what his practice consists of. Part of it reflects the fact that his name is different, but part of it, quite frankly, is how he introduces himself to every patient that he sees. Now, that may consume no more than 3 minutes of the encounter, but 3 minutes in the current era is fairly valuable. As all of you are aware, there are significant pressures on providers at all levels of the food chain. And any opportunity to try to increase face time for direct communication, I mean, that's what all of us want as patients. So Sri made a video, and it's a brief video just introducing himself, introducing Dot.
Hi, my name is Dr. Sri Koka, and I'm a
Dot.
consultant of prosthodontics in the Department of Dental Specialties at Mayo Clinic. I'm very much looking forward to seeing you at your first appointment that's coming up soon. And with this short video, our goal, Dot Weisheipel's goal and mine, is to introduce you to what you might be experiencing at that first appointment so that we can best serve your dental needs. Also, many people ask us questions about ourselves. So I'm going to take a couple of minutes and give you a bit of background about me.
So those questions often were, are you male or female? Before the visit. Where did you train? Do you speak English effectively? Can you communicate with me? And more importantly, for a lot of our patients, because they see so many providers during their visit, why am I seeing you again? What can you offer me? What can you do for me? That's a repetitive part of his day.
So with that short introduction, as this video draws to an end, I'd like to give you a homework assignment that will help us best serve you at your first appointment. Many of our patients come here looking to improve their smile or rid themselves of some pain in their mouth, or else to be able to speak or chew better. So with those three things, smile, comfort, and function, I'd like you to think about them so that you can tell me when you get here which of those is the most important one to you. Many times there are different treatment options and they address one or more of those options better or worse. So if we know ahead of time what you want, then we can give you the treatment option that best suits your needs. We really, really look forward to seeing you at your first appointment. We're very excited that you're coming to Mayo and to see us, and we hope that you have safe travels on your way here. All the best.
So what he's done then, he's framed the visit. And that's a large part of my clinical practice when I see someone in clinic framing a visit. I do that 8 to 10 times a day. And think about that, 8 to 10 encounters over a day. In dentistry, it's significantly more because they have a higher clinical volume than we do. That's 30 minutes a day that he saved from his clinical practice. We're going to start analyzing this in a more rigorous fashion, but frankly, that's an opportunity that a provider can understand. I mean, that's an opportunity that all of us can understand. Now, the other opportunity that I think is germane and quite powerful is medical education. So I serve as the director for the medical residence in rotative cardiology, and duty hours are a powerful tool, but they've also had an incredible impact on our opportunity to teach people. Now, for those of you who are familiar, duty hours began in 1984 after the death of a young lady here in New York from a potentially preventable drug-drug interaction. It was at a period where 2 residents were assigned to cover a very busy hospital practice. As a result of that, the first ruling in New York was an 8-hour work week. Now, the 8-hour work week has evolved dramatically since then. I'll let you read through these. The one that's the most germane is the maximum continuous duty period of 16 hours for first-year residents. That means if you're a brand new intern just out of medical school, when you arrive for night call for your 1-week rotation on cardiology, you'll arrive at 6:30 at night. You'll be there until 10:30 the next morning. That's your duty hour. And you've got to go at 10:30. There's no negotiation. You've got to be gone at 10:30. The consultant, the educator, he or she arrives at 8:30 in the morning. That gives a 2-hour overlap between teacher and learner to try to cover any educational goals, as well as deal with anyone who's acutely ill, put out any fires that are on the service. And frankly, it's taken a real impact on our capacity to educate. We've surveyed program directors nationally. 60% of them say, yeah, this is a problem trying to meet our providers' needs. When we talk to the interns and residents, they talk about less time for formal education activities, less time for conferences, less time for informal education, that sort of bedside conversation, less ambulatory training, more handoffs, because when they leave, they've got to say, here's my patient, can you take care of them while I'm gone? So in my mind, that's an ample opportunity for social media tools. It's an asynchronous encounter. Fundamentally, these tools allow you to connect people who are separated by time or geography. And that's truly what this is. Beyond that, from an educational perspective, you can build learning tasks for a group around a specific task or problem. And it can serve as an archive. So what we're doing is we're building a Khan Academy for our medical residents. It's going to consist of a series of 40 lectures, each about 20 minutes in duration with audio overlay, with a social media sidebar. So the intern who's on call that night can watch a video about a patient who was admitted that night. Let's say they admit someone with chest pain. They can watch a 20-minute chest pain video, and if they have a question, they can let me know, and I can respond, and I can engage them, even though we're not in the same room or in the same time zone. And that's a social media tool for a specific social media opportunity in a clinical practice. And that's my take-home message. If you want to engage your providers, help them find the opportunities these tools can help address. I mean, this can improve content by creating a transparent online repository of data. This is a creation opportunity because these reservoirs of knowledge are scalable. Instead of me talking just to the house staff, this is me talking to anyone who shares in that conversation. It creates networking opportunities for the house staff. And frankly, if they're going to be good at this when they leave, they've got to start using it while they train. And moreover, we expect our providers to partner with patients. We need to partner with them when they're learning how to do so, or we're not going to be successful. I've seen other opportunities that people have used at the Mayo Clinic. I've seen residents create a closed Facebook group, which fosters group expectations of professionalism and allows for more effective notification. I've seen residents tweet national meetings. At the ACC, there was some really clever use by cardiology fellows who were leveraging what they were learning, but also networking at the same time. They would tweet, hey, I'm doing a poster, and if you were around who'd like to see it, it'll be at 2 o'clock. Please come by Hallway C and take a look. And it's smart, and it's effective, and it works. And for the medical program directors I meet with, StudentDoctor.net is a powerful, powerful tool. 40,000 active members, 2 million unique visits, and 12 million page views a month. It is for medical residents and fellows who are in training trying to decide where they want to go. And if our program directors aren't part of that conversation, they left a hollow footprint where the truth is defined by someone else. I've seen residents in our own practice build wikis that they own and curate. And we talked about originally that blog. The key is not to bill it solely as a blog. This is an educational website with social media tools associated with it. If it's presented as a blog, you'll get a different response from providers. But these tools meet a specific educational goal and need. Fundamentally, these learners, these millennials, they're the first to grow up with iPads, with MP3 players, iPhone, and Twitter. This is how they function. And our educational recruitment, our educational engagement and training has got to reflect that new reality.
So yeah, we'll talk research, so it's weird for me to be the one to talk about medical research, but I'm actually the author, one of the authors on this paper, okay? So this is a story about spontaneous coronary artery dissection, which he'd be way better at telling you about, but we have a video to explain it.
Is that replaced by a video now?
This is what
Replaced by video,
happens
yeah,
during a
exactly.
spontaneous coronary artery dissection. A tear develops in the inside of a coronary artery, allowing blood to create a split between two layers of the wall. This may result in a loose flap of tissue on the inside of the artery. The flap, or a blood clot that forms in the damaged artery, can block blood flow and potentially cause a heart attack.
So spontaneous coronary artery dissection affects more women than men, and often around the time of pregnancy. And this is a story of actually medical research being turned on its head by social media. Catherine Leon was 38 years old when she had her second child, and she was feeling kind of fatigued afterwards. She went to the doctor, who said, "You're supposed to be fatigued, you just had your second child." But then she started having chest pain. She went to the emergency room. They said, "You're way too young for a heart attack." Turns out she was having a SCAD, was having a heart attack, and had bypass surgery at 38. And then she went home and said, "Am I more likely to have another one, since I've had this happen once?" And her doctor said, "I don't know." I mean, she didn't say it exactly like that, but she said, we don't know, because the largest case series that's been reported previously is 48 patients, and it's not big enough to know whether you're more likely to have it or not. So she said she felt like she was sitting on a ticking time bomb, and that drove her online to this group sponsored by Women Heart, which is the National Association of Women with Heart Disease. Women Heart had this support group, or had this site, and Catherine did a post called "All the SCAD Ladies, Put Your Hands Up," and among those who did, among the 60 women who did, was Laura Haywood Corey. Laura and Catherine conspired with each other that when they went to an event sponsored by Women Heart, they met with Dr. Sharon Hayes from Mayo Clinic, who's the director of our Women's Heart Clinic, and they went to her and they said, "Would you want to study us? I mean, we've got this group of 60 self-identified women already with SCAD. Would you want to study us?" And Dr. Hayes saw this opportunity, talked to some colleagues and said, "Hey, what if we tried to create a virtual registry where we could start to pull in larger numbers of patients?" And they also created a SCAD clinic, but they had got approved by our institutional review board for a 12-patient pilot, to see if it was even feasible to create a registry like this. Well, they had meant to get this on our clinical trial site, but Catherine initiated this, actually went back to the SCAD ladies group and posted it there, and within a week they had 18 volunteers for a 12-person study. So it never even got on our website. But that wasn't the hard part. I mean, in a sense, that was the hard part. The part to really show whether it was feasible or not was that they had to get the records from all these women. But within 6 months, they got the records from one woman from New Zealand, 2 from Canada, 1 from the UK, and the other 8 were from the US. And so it was. They told the others who had volunteered that they could wait in line and they could get in the next study if there was one. Because the pilot was a success, it led to 2 more studies that are currently going on, where I think they're close to almost getting filled now. For one that's a 200-person registry that will then give us an opportunity, give all of us as a group, an opportunity to develop some hypotheses. Like the women who had been online talking had some very sophisticated ideas, like, are birth control pills related to this? I mean, they had a whole bunch of different ideas. But now with 200 women that will be in this study, as well as a biobank where you can look at some genetic relationships, there's an opportunity to really move this research forward, and led to this story being in New York, in the Wall Street Journal and published in Mayo Clinic Proceedings. But the real story here is how normally in medical research you've got the researcher, the scientist, the medical professional saying, "Hi, I got an idea and I want to see if some patients will come and help me do my research." This was the other way around, the patient saying, you know, it's not good enough to not know, and I want to help facilitate making this happen. The moral imperative.
So this is why I do 30%. I mean, for me, this is fundamentally the right thing to do. This is truly the right thing to do. And I want to try to frame that discussion, if I could, why I think this is a moral imperative. I mean, first of all, you have to understand this is a unique moment in history. PubMed lists 21 million citations, with one new citation every minute. There are over 200 cardiac journals that are published on an annual basis. I run 3 different clinics in cardiology, we have a triage system. I looked at active diagnoses for that clinic. There are 324 diagnoses that can get you into that clinic. If you look at National Guideline Clearinghouse, which lists all the guidelines, there are 328 cardiac guidelines available, 215 applicable just to heart failure, which is my area of expertise. So there's a hell of a lot of data out there. And more of that data is online. It's transparent, and it's accessible to both me as well as my patients. So you have to ask, does the argument that I'm the only source of the right answer, that the patients can't advocate, educate, and engage on their own behalf, does that pass the straight-face test with that much data flowing my way? And it's not just information overload. This is a time motion analysis of floor nurses, looking at how much time they spent in a variety of tasks over a 10-hour shift. They spent 35% in documentation, 17% medication administration and reconciliation, 21% care coordination, 7% getting vital signs. They had 20% face-to-face time. So every individual who's involved in clinical care has to deal with a hell of a lot more information than we ever did beforehand, and has a hell of a lot less time to spend in face-to-face encounters. So is it any wonder that more and more people are looking online for knowledge and support? That's what I would do. That's what any of us would do. The value of their interaction online relies on two things. Access to the conversation. They've got to be able to participate in the conversation, right? And the quality of the knowledge shared. And our obligation as providers is to help shape conversations that have value to our patients. But too often providers say they don't want to be sued. I'll pay for my time online. What about HIPAA requirements? And are so risk adverse, we don't participate in the conversation to any extent at all. All of us in this room are the lived experts in our own disease. Every one of us are. Media access has evolved to the point that all of us in this room are going to have access to the same shared knowledge base. Our obligation as providers is to be partners with our patients and walk with them on their journey, online and offline. We can help shape the conversation, leverage information, and ensure that credible content is available when patients need it. Now, I want to talk about vaccine hesitancy for just a minute, and I bring this up because it's germane to me. I mean, I have a 4 and a 5-year-old, and when Eva was seeing Aaron, our pediatrician, we spent 5 minutes of that encounter talking about whether we should vaccinate her or not. I'm embarrassed to admit it, but we did. Despite the fact that Eva, in her preschool class, not in her class, but at the school, had a colleague, or child, not colleague, they don't, I guess she would say colleague, a child with a solid organ transplant. So despite the fact that I knew that, we still talked about it. And you look nationally, each time a pediatrician or primary care provider talks about vaccines, it costs them 5 to 10 minutes per conversation. By 24 months, that's 14 vaccines and 8 visits. Beyond that, there have been lawsuits brought against pediatricians for not having vaccinated children when parents refuse to get them vaccinated. So since Andrew Wakefield's now fraudulent study was published 13 years ago, connecting autism and vaccines, there's been a dramatic drop in MMR vaccination in the European Union, with a marked increase in measles and mumps. In 2011, the outbreak of measles affected 33 countries, with 10,000 in France alone. In the US, 80% of providers report 1 vaccine refusal per month. 8% report 1 in 10 patients refuse a vaccine. Now, I think these conversations happen in large part because we as providers haven't participated in that conversation. And our moral obligation is to be a part of this process, not sit on the sidelines. Physicians must partner with patients in content creation, curation, and decision making. We've got to leverage the content, leverage the conversation, and leverage the good. And I always tell doctors, you need to start small. Begin with a meaningful transaction. make good content available to a willing patient. That's an easy step that all of us can take. We also need to develop more aggressive training requirements for our medical students. In 2010, only 10% of medical schools offer social media policies, which is embarrassing. And we need to have clear guidelines institutionally for engagement, clear, meaningful guidelines, the rules of the road, if you will. And finally, I want to remind all of us, you've got to advocate for those who may be excluded. And there are a lot of them. Remember the access angels who are in our communities, the libraries, houses of worship? They're an important part of our network, and they need to be supported aggressively. For a lot of our patients who don't have the income to have a computer, they'll have a smartphone. So make sure your content is M-capable. It has power and access value to them. Don't forget the disabled or the chronically ill. They're the ones who can benefit the most from this conversation, but are often excluded. And remember those with rare diseases like SCAD, who geography can isolate, who can be brought together in this kind of a network. This is the right thing to do.
And just to put a face on that, I want to come back to POTS. We talked about POTS, and this is a video that Dr. Phil Fisher did using a flip camera, talking about some of his research relating to POTS and how it helped a little girl named Haley. Haley was 13 years old, lives in Lake Arrowhead, California, and had gone with her parents to Disneyland on her 13th birthday. She woke up that night after her Disneyland trip vomiting, and for the next 6 months was vomiting 10 to 12 times a day, every day. Her mom took her, she went to all sorts of specialists all over the place, a couple of big children's hospitals. Finally was told, you're never going to get an answer. I mean, her mom was told, you're never going to get an answer. She's already seen too many doctors, had too many tests. She just needs to go home and get counseling. She had seen a gastroenterologist who told her that she needed to take fiber. I mean, she lives in Lake Arrowhead, California, a mile in the sky above Los Angeles. Had to start wearing a diaper because she couldn't make the trip up the mountain because there wasn't a restroom along the way, and so she was having accidents on the way up the mountain. One night, her mom was up Googling and came across a blog post by a young girl who she said looked just like my daughter. Her daughter was down to 76 pounds. Haley was down to 76 pounds at 13 years old. But the little girl said, you know, I've got POTS. I feel icky a lot of the time, but Dr. Phil Fisher is a wonderful man. He really helped change my life. And that linked to that video from Dr. Fisher, which then Christine took the video to her next appointment with the local doctor and said, do you think it could be POTS? And the doctor said, POTS, that's just a throwaway diagnosis, it's not even a real thing. And she said, really? I mean, this is a Mayo Clinic doctor talking about this. Are you sure it's not a real thing? But anyway, that gave her the courage to go across the country to come see Dr. Fisher. And after they did, I got this comment card where she's telling the story of having come to Mayo Clinic and to see Dr. Fisher. I got in touch with Christine and asked her if she wanted to write a story on our Sharing Mayo Clinic blog. She agreed to do that. And then when I was in San Diego a few months later, had my flip camera, drove up the coast, and went to see Christine and interview her. And here's just a minute or so from what she had to say about this.
First of all, I feel like I have a decent level of an education and intelligence. I mean, you know, I'm a college graduate, but I'm not in the medical field. But a lot of the things you come across are either, you know, too medical jargon, like a lot of sites you come across say you have to have a password to get into, or this is only for doctors, or they're medical abstracts, or they're just too simplistic, like, you know, for new moms and babies. And I just really lucked into you know, finding the Mayo Clinic website, and I'm not good on the computer, so I think I'm lucky I found that. And it probably never in a million years would have occurred to me to think to go, let's go look at the Mayo Clinic and find out what they have there. And they live there so far away, I never would have thought of looking for a doctor specifically at the Mayo Clinic. I would say be a loudmouth for your kid, be vocal, be an advocate. I mean, I cannot tell you how many times we heard no. So many times. It had to be close to 100 from different doctors, nurses, specialists, clinics, the ER. Who's going to advocate for your child if you don't do it? I mean, Haley could still be in pain if I hadn't lucked into finding Dr. Fisher, but I just wasn't going to give up. There's no way.
So when I saw Haley, she was pushing 100 pounds, so she was, you know, getting kind of chubby actually. No, but she was about 100 pounds. Having this video led to us being able to pitch the story to ABC News, where they used the video of Christine on their website, again for one of these 1 to 2% conditions, diseases that affects a lot of, that do affect a lot of people when you combine them all together, but in some very profound ways. But it isn't all just about having patients come to Mayo Clinic. This is an email that Dr. Fisher got from a woman in New Jersey whose daughter never came to Mayo Clinic, but because of the video, they were able to have that conversation, a different conversation than the one that Haley had in California, where she was able to get diagnosed. And anyway, she says, if I didn't find your video on YouTube, I don't know how long this would have gone on. I'd Googled tachycardia, orthostatic teenage female, some of our other symptoms. What a great public service that is to leave a contact number. I can't thank you enough for it. And now I want to just, what this has led to is Mayo Clinic's significant investment in social media and really ramping up, and not only what we're trying to do for ourselves, but as Dr. John Noseworthy, who's our CEO, says in this brief clip, how we want to help others in the healthcare industry be able to take advantage of these tools.
I'm going to talk a little bit about our founders. They saw it as their mission to reduce the burden of disease everywhere, not just in their rural practice here in Rochester, Minnesota over 100 years ago. Following in their example, I'm proud to say that Mayo Clinic has been and intends to be among the leaders in using social media in medicine. I think it's only fitting that we should help this happen. This one is not about competitive advantage. This message is as it should be. It's all about the patient and how these tools can help us all serve them better and work together with the patients and their families for their health. We at Mayo Clinic are committed to helping our colleagues around the world who want to learn from us and with us how to apply these revolutionary tools to promote health, to fight disease, and to improve health care.
That's why Dr. Noseworthy was the champion for creating our Center for Social Media, to help Mayo go beyond the PR and marketing use of social media and say, how can we apply this throughout our practice, education, research, and then also to help others, other organizations interested in using these tools. That's why we created the Social Media Health Network, which is an awful lot like that blog council that Andy Cernovitz formed, but this is just for health. And we now have more than 110 member organizations that have joined with us. Here's a list of some of those. And we've met through this opening keynote to sort of set the table. We have just 5 minutes or so for questions now, for questions and discussion. We'd really welcome that. We actually hope the conversation will keep going on Twitter and elsewhere. And we're also here for the next day and a half, and so we'll be participating in the discussion there. But if anybody has opening questions or strenuous objections, let's have at it.
Again, Lee's birthday is this week.
Right. Any questions? I know we've got, yeah. So as we started, before we created the Center for Social Media, we had 1.5, okay? 1.5 FTEs dedicated to it. When we were approved for the Center for Social Media, we added 8.1 more, with Ferris being the 0.1. And again, we're getting 3 times, we're getting a 300% return on investment there too, because he's really dedicating a lot more time. But those 8, our goal is to help train our 58,000 Mayo Clinic employees. So it's to maintain our overall presence, but then to say, okay, we want to meet with pediatrics and talk about vaccine hesitancy and how can we leverage these tools to do their work. So it's because of that broader, engagement within the organization, and how can we apply those tools everywhere. And then the other part is just the fact that we have this Social Media Health Network. If we were just focused on ourselves, it might be a little bit less too, but we're also wanting to do this outreach to help other organizations be able to use the tools too, so we staffed up a little bit more for that. Yep. Thanks. Well, so one of the, just to repeat the question, one of the things about, getting to Mayo and referrals and service coverage. So actually this app that we just did has a lot, that we just launched on my birthday, actually, on Tuesday. It was a great birthday present, yeah. That has a bunch of that information. That community that we created at connect.mayoclinic.org, in addition to patients being able to connect with each other about specific conditions, they're able to ask questions about, getting to Mayo. So certainly to be able to answer questions like that, but then also the fact that we can make resources available to patients, whether they're coming to us or not. I mean, actually, we see that as helpful.
I mean, these are archived resources that exist online well beyond their date of creation. I mean, some of those comments regarding the POTS video came out 4 years?
4 years ago, yeah.
And there are patients who never came to the clinic to be seen, but still had access to content of value. And still have the capacity to engage because we always include contact information as well.
Yes?
How do you, at the same time, encourage use of social media and also affect your policy?
Well, so part of the question about encouraging it while enforcing the policy, first of all, our employees are going to be engaged. I mean, they're just like other people in society. They're going to be engaged, so we already have that risk. So the big thing is that we're saying, how can we, we're providing training like the social media residency course, which is a day and a half, and we're not expecting everybody to go through it. But we're putting tools online. We're putting, and we're trying to do it through some of the traditional tools like our employee online newsletter, through our, employee website, just getting in front of people with it. And, it's an ongoing thing. And then we're also doing a video for new employee orientation. That'll be about a 5-minute video that'll introduce people to where we are online and then also direct them to our training resources and guidelines.
The employees you have and the timelessness of social media, do you have people working on your staff?
We don't have people working 24/7. We do, fortunately, though, have a campus in Florida and a campus in Arizona where they don't observe daylight saving time. So in the summer, they're actually on Pacific time. So that does give us more of that. I mean, we just have to. I mean, I think there's. Would 24/7 be ideal? I suppose, but people also have reasonable expectations that, first of all, they're just thrilled. I mean, right now they're thrilled. Oh wow, they responded. They responded at all. If you respond even the next day, if they've done something at night, you're going to be okay. On the other hand, we do have monitoring tools there that if, we might get an alert about something, if there's an issue out there that, because I did wake up one morning with our Facebook page full of, it was a Latvian-Russian civil war. We'll just leave it at that because we don't have time, and maybe at a reception or something we can talk about that. So, yes?
How do we find its presentation?
So if you go to socialmedia.mayoclinic.org, it's on the, well, I'll just go there. So,
It's asking for a password.
actually, no, if you go to socialmedia.mayoclinic.org, so I'm going to the front, so this is the public site. The post is sold out, and we'll just encourage Chris to tweet it or whatever too, to tweet the link, that'll be there. But the presentation is here, and you'll see these eerily familiar slides. That's the public site. Now over here is our Social Media Health Network community site, and this is the member-only site where we have some additional resources. And so any employee of a member organization gets access to this site. But the public site over here is just, so that one's network.socialmedia.mayoclinic.org. This one is just socialmedia.mayoclinic.org.
After the conference, we'll send out an email
One looks
information
that.
as well as links to presentations.
Anything else? Yeah. Oh, okay. Daily leads, well, so this would be my calendar. That's daily, Daily leads is our meeting at 9 o'clock Central Time every morning, where the people working in media relations get together and talk about what's in the news and what might we pitch and what stories do we have coming up. So, yeah.
What's that silly looking fish?
Oh, that's Bitly. I mean, that's the trending tweets. So 17, I'm thinking some of that shortened link that I did about the Mayo Clinic app has gotten some clicks. So, all right, thanks very much.